I'll now introduce our first speaker who will be presenting on a myeloma overview, a topic that is new to some and a wonderful refresher before diving in deeper for others. Dr. Angie Young completed her hematology training in South Australia and a clinical myeloma fellowship at the Royal Adelaide Hospital. She is working as a consultant hematologist at the Royal Adelaide Hospital and Lyell McEwen Hospital. Her areas of interest involve plasma cell dyscrasia, including myeloma and amyloidosis. Welcome, Angie.
Hello, good morning, everyone. Thank you for this opportunity to, I'd like to say give a speech, but I think, let's put it this way. Let's have a chat about what myeloma is, and we have a brief overview. We've got a few other speakers who will be covering on the treatment, on investigation. So I haven't really touched much on that, but let's try and let's go back to basics. So the first question is, what is myeloma? So myeloma is a cancer. It's a cancer involving the bone marrow. And in my next slide, you will see what the role of the bone marrow is. However, what happens in myeloma is that there are certain type of white cells which then become plasma cells, which are the immune system of the body. And in myeloma, there is an abnormal production, and some of these plasma cells which are abnormal are also increased in numbers. These abnormal cells can then deposit in the organs, such as the kidneys or in the bones, and they cause quite classic myeloma symptoms. Of course, not everyone presents the same way if they've been diagnosed with myeloma. We'll touch on a little bit about that later. So this is a slide, the most recent one that I could find on the statistics of myeloma in Australia. This is from 2021. For 2021, there has been an estimated 2,423 people diagnosed with myeloma, slightly more males than females. Of all the cases of cancer that were diagnosed in 2021, myeloma accounted for 1.6%. In the number of deaths from myeloma in 2021, there were a total of 1,074. To put it into perspective, in terms, if we look at the mortality from cancer, so deaths from all sorts of cancer, the deaths from myeloma accounted for 2.2%. So in a way, when we look at the statistics, myeloma is actually not that common a cancer, but it can be quite debilitating. Now the chances, so this the next line, it says that you have in general, people have a 54% chance of surviving for at least 5 years with myeloma. But bear in mind that this particular number was from 2013 to 2017, and there's been many, many changes in the treatment of myeloma since then. I expect that the number, and I'm hoping that the number will be higher when we have our next round of statistics. So unfortunately, the pictures are not that clear, but what I have here on the left in the diagram is the numbers of a different type of cancers in Australia, diagnosis in Australia, and you can see that myeloma, which is highlighted in brown, is already in. So, it is relatively common, but it's not one of the most common cancers diagnosed. This on the diagram on the right shows the survival. So it's a bit hard to see, but in general, it just says the rate of diagnosis, not the survival, but the rate of diagnosis of myeloma from 2017 to 2021, and you can see that the numbers in general, the numbers of people diagnosed with myeloma has been slowly increasing. Yes. So what exactly is myeloma? What is a bone marrow? Now we have bones. This is our skeleton. We know that the bones are hard. And that's, if you look at the middle diagram, there is a compact bone, and this is the cortex of the bone, and that's the hard calcium, the calcified part of the bone. But inside, there is a spongy part, and this is the bone marrow, and the bone marrow makes our blood cells. It makes, if you look at the diagram on the right, the red cells. It makes white cells, which are the overall immune system of the body, and it makes platelets. I call the platelets the tiny frontline guts, the guts of your immune system. The platelets are the one, if you cut yourself, I always say that the platelets are the ones that get activated first to try and activate all the proteins in your body to start healing that cut. Now, the white cells, there are different types of white cells. We have the lymphocytes. So we are a little bit focused on the first one. Lymphocytes are there are B lymphocytes, there are T lymphocytes. These are the antibodies of the system. We have the monocytes, which are also reactive white cells that try to defend the body against any infection. So they would try to eat together with the neutrophil, which is the last one. They will try to eat up the bacteria, to try and eat up the invaders when you have an infection. The other two is eosinophils. Eosinophils are elevated when you have an allergic reaction. So they try to increase and say, no, we need to deal with it. So each of these different type of white cells play a different role in the immune system of the body. With myeloma, what we are focused on is on the lymphocyte, that particular lineage. So what happens in myeloma? A healthy bone marrow on the left would produce lymphocytes. B lymphocytes is what we are interested in. These B lymphocytes, some of the lymphocytes would then go on to differentiate into plasma cells. The plasma cells secrete antibodies, and these are the normal antibodies of the system. So if you've had if you put it in very basic terms, if you've had a vaccination, these are the plasma cells. These your immune system recognizes that vaccine, and the plasma cells are the one that remembers the antigens here with this little Y-looking thing. They remember the exposure, and they're the ones that can then be primed and activate the immune system if you encounter the same infection again. In myeloma, this process goes a bit haywire. So the bone makes the B lymphocytes. Unfortunately, something triggers the bone marrow to then just make a particular type of plasma cells. So not just an all-round general, plasma cells secreting all sorts of antibodies. It just triggers one type of plasma cell to be produced in excess. And therefore, that particular plasma cells, there will be a lot of it. It will only be secreting one type of this antigen, so that Y thing. And because it's only one type, we call it a monoclonal protein. You may have heard that sometimes when you talk to your doctors. So that's what it means. It's a one type of that kind of antibody, and that's a monoclonal protein. On the right, that's just a little bit of a diagram of what a monoclonal protein looks like. So with the entire Y diagram, so in myeloma, sometimes the plasma cells would secrete this whole structure. We call that the monoclonal protein. Some people have a IgG, myeloma. Some people have an IgA myeloma, and that is just the type of the chain in light green, because some of the chains are IgG, some are IgA. So this helps to identify what type of monoclonal protein is secreted by the myeloma. In some cases of myeloma, it's not the entire structure that is secreted. These abnormal plasma cells make too much light chains. So light chains, and as a part of the structure, light chains are the dark blue aspects. So the little side chains here, they consist of kappa and lambda light chains. So some people's myeloma, the plasma cells only secrete this particular bit of the antigen. It can be kappa or lambda. And so for some of these myeloma classifications, we call them light chain myeloma. So it's still a similar process. It's still an abnormal production of the plasma cells in that process, but what that plasma cells are secreting is what, is the name that we give the myeloma. So it's IgG myeloma, or it's a kappa light chain myeloma. It's based on this antigen and what is being made in excess. Thus, a monoclonal, does an IgG myeloma behave differently from a light chain myeloma? Sometimes it does. Light chains, this particularly big, can cause quite a lot of kidney problems if they are too high. This is something that will be determined on a kidney biopsy. But in general, whether it's a whole entire antigen, whether it's a IgA, IgG myeloma, whether it's a light chain myeloma, we look for similar symptoms. So the common symptoms of myeloma, for an easy acronym to remember is CRAB. Why CRAB? Myeloma can cause increased calcium in the blood. In quite severe cases, this can be associated with people who have got abnormal, very irregular, abnormal, almost at times life-threatening palpitations, because they just cause the heartbeat to go quite haywire. It can cause confusion if the calcium levels are too high. Some myelomas present with kidney problems. So the myeloma protein or the light chains actually deposit into the kidneys and affects the function of the kidneys. So, the kidneys filter out, the blood and removes a lot of toxins. And then that process is impaired if the whole kidney has got myeloma deposited in there. So people with kidney problems may be very lethargic. They may find that they may be going to the toilet quite often, or that their legs are quite swollen. They just seem to be puffy, putting out with fluid. And that's not explained by just a short period of just drinking too much water. This is something not right. And I have had patients tell me that they've gone up 2 or 3 shoe sizes, and that's how much the leg swelling has occurred. A stands for anemia, so a drop in the red cell count, fatigue, lethargy, just general muscle weakness can occur if the anemia is quite significant. The other difference for myeloma, and this is one of the more, I would say, not common, but it's a warning sign. So some people who have unexplained bone pain, backache, unexplained persistent, a scan has subsequently been done and it shows lytic lesions. So lytic lesions are a little bit different and quite different from osteoarthritis. So lytic lesions are described as little punched out lesions. So they are, if you look at a plain film, X-ray film, you can sometimes see little holes, and that's really quite abnormal. So when there are lytic lesions in any of the bones, one thing we always are aware of is, are we dealing with myeloma? Does this person have myeloma that's causing this pain? The other bone involvement that can occur is crush fractures. So when there's myeloma involvement in the bones can get quite frail, for want of a better word. They get quite frail, and that results, if there is some stress on the bone, that can result in just increased crush fractures. So crush fractures is when the bone vertebrae just becomes a bit more compressed. Sometimes in myeloma, some people may have plasma cells, the abnormal plasma cells, growing out of a normal bone, and that can be causing symptoms as well. Other features, which are non-CRAB features of myeloma, people can have weight loss, they may have fevers. Some people with a very high protein, high plasma cell count, secreting a lot of protein, can have blurry vision because there's a lot of protein. It may affect the vision and can be a bit thick, blood can be a bit thick, or headaches as well. So this is what we call hyperviscosity syndrome. That's something that we have to be really careful about. So what investigations do we do for myeloma? There are a few. The first investigation we need to do would be blood tests. We do a blood test because we can look for anemia, remember low red cell count, and we can look for high calcium level, and we can check your kidney function and do that on a simple blood test. In addition, some blood tests will be sent to the lab to look for an amount of that monoclonal protein. Remember the abnormal plasma cells secreting the abnormal proteins here. So we can send that to the lab, and that's called serum protein electrophoresis. That test is not immediate. It doesn't come back the next day. It takes a few days to run, and in some labs, it may take 5 to 7 days for that result to come back. We can also check on the blood test how much circulating kappa and lambda light chains there are in the blood. And all this is to help us screen and check whether someone has myeloma. Another blood test that we like to do is a urine test. Light chains circulate. Sometimes light chains, if there's a lot of light chains from the myeloma, they can go into the kidneys, and the kidneys can secrete the light chains as well. It's useful and it's helpful to us to check whether there is any light chains that is in the urine. And these light chains are called Benz-Jones protein. I like to ask for a 24-hour urine collection. Sometimes I find that the secretion can be quite intermittent. So over 24 hours, I like to know how much Benz-Jones protein is being secreted. It also gives me the information. It also lets me know how much protein we are losing in 24 hours, if there are any, because it helps me know about exactly which part of the kidney is being affected by myeloma. On a side note, if someone is losing a lot of protein just because of the way the kidney function is being affected, one of the reasons why I like to do a 24-hour urine, especially during the workup phase, is because there could be a hint that we may also have coexisting amyloidosis. I'll touch on that a little bit later. So back to the investigations we do for myeloma, the third thing we do is we do a scan. Now, it is recommended, the MSEC's come out with recent guidelines, it's recommended that we do a skeletal survey. What is a skeletal survey? It's basically imaging of the main bones of the body, so the spine, the skull, the long bones, the femur, the humerus, because myeloma tends to affect that, and the ribs as well. The recommendation is for low-dose CT scan because it's more sensitive, and it does help to pick up more myeloma. Just bear in mind that unfortunately, what we call a CT skeletal survey is actually not Medicare reimbursed. And depending on your location where you stay, it may be that the only available modality is an X-ray skeletal survey. Now, it's not that the X-ray is not good. It's good. The CT is just a little bit more sensitive. But if we are working out for myeloma, we'll do whatever we need to. And a dedicated CT scan can then be ordered if we can't do a skeletal survey, if you have any symptoms. Some of the other tests that we can do for workup of myeloma will include MRI scans. For example, if someone has ongoing back pain, the CT scan of the spine did not pick up much, then we may request for an MRI scan. A PET scan, which is a kind of is a different scan. A PET scan is a nuclear medical scan, nuclear medicine scan, and what it does is a little bit of a tracer will be it will be given as an intravenous injection, but the PET scan looks at activity. It looks at the glucose metabolism, so like the sugars, how your body is using up some of the sugars. And in spots where there is active myeloma or active, for example, other types of cancer like lung cancer, that PET scan is useful to tell us which spots has got some activity going on. So it's just another way of us trying to diagnose whether the bones and is there any other parts of the body, not just the bones, that are affected by myeloma. Now, the PET scan for myeloma, again, is not a Medicare rebatable test. So access to this is quite limited. It's limited by hospitals, it's limited by the radiology department for where you're receiving treatment. And the final, test, we do a bone marrow biopsy. Now, some of my patients ask me, if I already have a blood test showing that there's a high monoclonal protein, if I have a blood test showing that I've got, really this amount of light chains and everything fits with correct, why do I still need to go through a bone marrow biopsy? I explained that the bone marrow biopsy is good. From the bone marrow samples, I can actually send for some tests that I can't get on the blood. What we look at on the bone marrow, or perhaps let's take a step back. What exactly is a bone marrow biopsy? So bearing in mind that some different centers do it a bit differently, I've just taken a very simple picture and I've copied this from the Royal Children's Hospital. But typically where we tend to do would be the posterior superior, this part of the pelvis, and it's the posterior part, so the back of the pelvis near the buttock cleft. We, patient will lie on the side, pull the knees up so that the bones are pushed backwards, and you can easily quite feel the bones there. The needle goes in. Remember, it goes into the soft part of the bone marrow between the heartbeats, and then the samples are taken out. It's usually, and I say usually because I'll jinx myself if I say that all the time, but it usually is a very straightforward procedure. It is local anesthetic can be given for that, and most patients will be fine the next day after. They might feel a bit of an ache, but it should be okay. What do we look at the bone marrow? So there are some samples that we take out and we look down under the microscope for the diagnosis. And I've got a little bit of a diagram on the right there. So the first thing we take out is we look at an aspirate. And what is an aspirate? When the needle is in, a little bit of the bone marrow, it looks like blood. So it's a test tube, it looks like blood. So it's taken out, it looks a bit like blood. We smear it on a slide, specimen A on the right side. And then we look at it under the microscope. There'll be little bone marrow bits there, and we can actually see the cells. As we smear it, the cells are spread out, and we can look at the cells in detail. It tells us how the white cells are looking, how the red cells are looking, whether there are abnormal number of plasma cells. We can count it on the slide. It also helps us to see what the plasma cells actually look like. Do they look like normal plasma cells? Do they look like they are quite aggressive plasma cells where there's a lot of dividing activity going on? The second bone marrow sample that we take would be a trophine, what I call a trophine or core biopsy, where there's no sucking up of the tubes. What we do is that needle goes in, is very gently rotated, and then a piece of the bone marrow without much manipulation, that piece of bone marrow is taken out. We put it into something that helps to calcify, some solution helps to calcify, and then thin slices are then cut and put in the microscope. So that's put on a slide. So that's specimen B. And what happens with that is we then we cannot look at individual cells this way because that's for the aspirate part. But what it helps us is it looks at the architecture of how the bone marrow is organized. Does it look orderly? Is there normal, what I call bone marrow productions going on? Are there enough red cells? Are there platelets? So it looks at the architecture and tells me if there is a lot of myeloma that is overtaking all the other normal bone marrow function. So this also just gives us information. On the right side in specimen C is a clot section. So if we take out an aspirate, we put a little blob on a little dish, we allow it to clot, and then we do the same thing. We put it in something that helps it to dry out, calcify it, and we cut little slides. And then that also is another way of seeing the architecture. Now, some places tend not to do clot sections anymore, and some do. So I've just put it here because it's still something that is useful. Section D would be similar to that of a core biopsy. So it's really just looking at the architecture. Now, what are the samples from the bone marrow we do that is very different from just a blood sample? So we send off, when we take the aspirate, we send a little bit off to what I call the lymphocyte for immunophenotyping, or what we call lymphocyte surface markers. It helps us to see with these abnormal plasma cells, what kind of markers are expressed there. So myeloma cells sometimes express abnormal markers. All this is just a support to support the diagnosis of myeloma. Sometimes, interestingly, not common, but interestingly, with the lymphocyte surface markers, some people may also have a coexisting condition, a lymphoma, which is a totally different disease. And we actually find that on immunophenotyping. So any information, when it comes to myeloma, I say any information is good. Immunophenotyping is what we sent for. The last and most important, well, not most important, but it's really a very important feature for diagnosis is what I call the genetic test. So there is the karyotype. Now in humans, we have 46 chromosomes. Sometimes people have very aggressive myeloma where the plasma cells, the abnormal myeloma cells, have mutations that make the particular myeloma really aggressive. So whether they present with full-on crab features or whether the treatments that you give just don't work for a long time. So karyotype is another thing, or fish. Fish is a fluorescent in situ hybridization. So that's also another way of looking at the genetic mutations of the abnormal plasma cells. So this is important, and that's why we still do a bone marrow biopsy or this test. We cannot do it just on blood. So this bone marrow helps us in the diagnosis, supports us in the diagnosis, and it helps us in prognosis as well. Sorry, I was just going to go back a slide. Now, let's go to the next slide. So we have normal B cell production in the top line. That's a normal bone marrow. Remember, we have the lymphocytes into normal plasma cells with a full range of antibodies, and that's normal. In myeloma, at the bottom one, we have abnormal plasma cells, quite a lot of plasma cells. They are secreting a monoclonal antibody, and these plasma cells cause the end organ damage. So they cause those crab features that I mentioned with high calcium, anemia, bone lesions, kidney problems. Sometimes though, some people have been diagnosed with this in-between phase, what we call MGUS. So MGUS stands for monoclonal gammopathy of uncertain significance, quite a long word. What it means is there are some plasma cells in there. They are secreting a monoclonal protein, but not at a high level and not at a high number. So they're kind of like, I like to call it pre-cancerous, pre-malignant. So there are enough plasma cells there. It's not enough to cause myeloma, but it's there. There is no crab features. There is no bone lesions. The calcium level is normal, no anemia, and kidneys are normal. For people with MGUS, there is an increased risk of fractures. There can be changes in the bone density, but there is no crab features. So I will touch a little bit on this about treatment later, but why is MGUS important? I think MGUS can be common. It can be diagnosed in up to 5 to 8% of the general population above the age of 75. So it's something that can be common as we get older. It doesn't mean it doesn't lead to myeloma, but with MGUS, our GPs and for general health, we should be monitoring the monoclonal protein once or twice a year to keep an eye on things. So remember, I've talked about the karyotype, the diagnosis, the genetics. We use the revised international staging system, the RISS, to stage myeloma. This is based on certain criteria. So we look at the albumin, which is the protein production in the blood. We look at LDH, lactate dehydrogenase, and that is more of a marker of cell turnover in the blood. And the beta-2 microglobulin, which is a protein on B cells and plasma cells. So if the beta-2 microglobulin is high, generally it does mean that the load, the burden of myeloma is high. Just a side note that the beta-2 microglobulin is filtered by the kidney. So if there's a problem with the kidneys, it's not going to filter it well, the beta-2 microglobulin is going to be elevated anyway. So these are the 3 markers that are based on blood tests. And then the next criteria will be whether are there any abnormal genetic mutations from the bone marrow cells, which we usually diagnose on a bone marrow biopsy. There are some genetic mutations that are higher risk than others. So why we stage now? Whether we are stage 1 or 2 or 3, it does not really make a significant difference in the treatment that we give. All treatment for myeloma is based on what we can get on PBS. I like to know what the prognosis is. in general, because I do sometimes, sometimes it can change the treatment. We may recommend that if someone is young and they have a higher risk myeloma, that some hematologists may suggest having 2 transplants instead of 1 transplant. I'm not going to cover the treatment part because I think someone else is going to talk about treatment. But in general, when it comes to myeloma and any type of condition, the way I think is as any information, as much information as I can get is better. So I like to know what the staging is. Now, you may have heard these terms. Some people, it's not just myeloma. Now, you may have heard about solitary plasmacytoma. Now, what is that? It is a similar condition, except that those abnormal plasma cells are not found in the bone marrow. There are no typical CREB features. What happens is some of these abnormal plasma cells just found in one place, and they cause an abnormal growth and a normal lump there, and we cannot find evidence of myeloma anywhere else. So this is what we call solitary plasmacytoma. It can happen in some people just in a spine, in a rib, in one particular spot of the body. Smoldering myeloma. Smoldering myeloma is when people have quite a moderate number of abnormal plasma cells on the bone marrow or on the monoclonal protein, but there are no CREB features. So there's no calcium, no kidney, no anemia or bone lesions on the scan to diagnose that. So we call that smoldering because they may develop myeloma soon, but they just haven't. Another condition is non-secretory myeloma. So patients with this, they do have abnormal plasma cells. And I'm just going to see if I can bring up this. So on the right side in this diagram, they have the abnormal plasma cells here. That's causing the typical features of myeloma. There can be bone lesions, high calcium, anemia, or kidney problems. However, those plasma cells do not secrete a monoclonal protein. They don't secrete light chains as well. So on the blood test, they have like no paraprotein or no light chains, but they have myeloma because when we do the bone marrow, we actually find the plasma cells. The next item is plasma cell leukemia. That is when so usually for myeloma, all these abnormal plasma cells are found in the bone marrow or in spots where myeloma affects. So if I have, if someone's got a lytic lesion in the bone, we do a biopsy of that and we can find plasma cells there. What happens in plasma cell leukemia is when there is circulating abnormal plasma cells in the blood. It is a sign either of aggressive disease, it is a sign of end-stage myeloma. In some people, they have got quite aggressive disease. This is how we diagnose myeloma, is when they have a blood test and we see abnormal myeloma cells in the blood. Now, there are some other conditions that can be associated with this similar kind of, you talk about plasma cells, but it's actually not myeloma. Sorry, just hold on. So it's actually not myeloma. POEM syndrome. So POEM syndrome is a disease, different disease entity. There is still a monoclonal protein there, but in POEM syndrome, they manifest quite differently. They've got neuropathy, nerve problems. They might have bigger, some organs that have been affected, like a big spleen, for example. They might have problems with diabetes or thyroid and skin changes as well. So POEMs is even though there's a monoclonal protein, it is a different disease from myeloma. I'd like to talk a little bit about AL amyloidosis, something I'm interested in, but it can coexist with myeloma. And what is AL amyloidosis? Amyloid is an abnormal protein. It's an abnormally folded protein. And in some cases, the amyloid itself is being driven by the abnormal plasma cells in myeloma. So it is said that in 10% of patients with myeloma, there can be amyloid as well. It's just that it can be hard to find. So AL amyloidosis, different disease, but can be driven by that same abnormal plasma cell. The final one is lymphoplasmacytic lymphoma. There are abnormal plasma cells in the bone marrow, but this part where the abnormality happens, is somewhere between the B cell and the plasma cell. So the differentiation bit, the part where the abnormal increase happens, is actually slightly earlier than the plasma cell stage. And this actually causes more of a lymphoma than a myeloma. So people do ask, can myeloma be inherited? My uncle has myeloma. Is this something in the genes? Myeloma is not considered a hereditary disease. It's not something that you have in the genes that you pass down. But the risk of developing myeloma does increase if you have first-degree relatives. So your parents, your siblings, if they have myeloma, then your risk of developing myeloma increases. If you've been diagnosed with prior MGUS, remember the extra protein, but the protein that doesn't cause the CREB features. If someone has had a plasmacytoma before, where there's only one spot where myeloma is found, then there's a risk of developing overall myeloma. If you're of African descent, yes, there is an increased incidence of myeloma, and if you're of African descent. So the African Americans in America, there's a big population of myeloma being diagnosed there. And if there's some prior exposure to radiation or benzene, seems to trigger the abnormal plasma cell population. I just want to put a note here that if there's prior exposure to radiation and benzene, it can also lead to an increased risk of other types of cancers. So not just myeloma itself. Just very quickly, treatment for newly diagnosed symptomatic myeloma. So who should start treatment for myeloma? Anyone who's symptomatic with CREB features should start treatment. What we are aiming with treatment is we want control of the myeloma so that we don't get further involvement. Our organs are stable, so it does not deteriorate. How about people with what we call, smoldering myeloma? Some patients say, look, I've got smoldering, I've got a big number of plasma cells, but why are you not treating me yet? Well, if you have a high number of plasma cells, abnormal plasma cells in the bone marrow, you don't have CREB features. However, there is a criteria called the biomarkers of malignancy. So if the bone marrow plasma cells are quite high, they're more than 60% of the entire bone marrow. If you have light chains and the abnormal light chains over the normal light chain, the ratio is above 100, or on the MRI, which is a much more sensitive test, we can find more than one spot, then we consider this as, we should consider this as myeloma, and anyone with those criteria should be treated as though they have symptomatic myeloma. How about the other conditions I mentioned? So solitary plasmacytoma, remember just that one spot. Usually radiation therapy is the main treatment. There'll be a few fractions of radiotherapy given and then monitoring after that. For MGUS, small number of monoclonal protein or small amount of monoclonal protein, no CREB features, monitoring should be the mainstay of treatment. There's no evidence to say that treating MGUS earlier makes a difference in the outcome. Who should monitor MGUS? And I think this is quite a varied opinions here. If you have a good GP who's very on the ball, who's happy to monitor, I would say a good GP should be able to monitor MGUS with the blood test as well. And at any sign or any development of symptoms, the scans can be organized. Now, in smoldering myeloma, where there is a high number of plasma cells in the bone marrow to consider myeloma, but you don't have CREB features, there are a couple of ways we can do depending on access to treatment. So the first mainstay is there's still no evidence that smoldering myeloma we should be treating everyone up front. So monitoring still remains the main way to go to proceed with smoldering myeloma. But there is some criteria which has been come up recently by the Mayo Clinic. They call it the 2-20-20 criteria, where some features, if there's a high enough number of monoclonal protein and high enough number of bone marrow plasma cells, that there has a higher risk of progressing to myeloma. So some centers and some hematologists would consider treatment in people who fulfill the high-risk criteria. that's not a widely adopted approach. It's not a standardized approach. So I would say we will have to discuss this with your hematologist. There could be other features that we're not aware of. The third option for smoldering myeloma that I encourage would be clinical trials. We don't know enough about smoldering myeloma. So enrolling to a clinical trial would be a good way to help future people know and help the clinicians know exactly what we should be doing with smoldering myeloma. In general, the treatment for newly diagnosed myeloma in general would be we give a short course of what I call induction therapy. If patients are appropriate, then we may consider an autologous stem cell transplant followed by maintenance therapy. If someone's a little bit on the older side of age and has heart problems and is quite frail, then autologous stem cell transplant is obviously not the best option. Induction therapy, appropriate induction therapy, plus or minus maintenance ongoing therapy can also be considered. Radiotherapy or surgery also may be necessary if the myeloma affects a bone site, for example, in the hip, where there is an impending risk of fracture, then surgery may be necessary to prevent fractures prior to starting therapy. All this, and also I should mention again, clinical trials. Now, all this should be considered and discussed together with your treating hematologist. Everyone is different. It's not a guideline ABCD that we follow. Treatment is targeted and it's aimed at your myeloma, your age, your comorbidities, and how you go about doing this. So we should discuss this with your treating hematologist. If there are clinical trials available, I also say please consider a clinical trial. Clinical trials do help us find out more about treatment options as well. Now, common question I get, can myeloma be cured? Unfortunately, myeloma is not a curable cancer yet. A lot of studies are being done. A lot of research is being done. We've made many progress in the past 10 over years of treatment. So watch this space. I believe that one day we can say, yes, myeloma can be cured, just not yet. Our main aims of treatment are to control. We want remission, where the protein is down, there's not much production of abnormal plasma cells. I think I'm running out of time, so I'm just going to quickly cover this bit about treatment because I believe it will be covered by another presenter later. But as of May of this year, there are a few PBS-funded treatment for induction. So the newly diagnosed myeloma, there's few new PBS-funded treatment and combinations as well. The common combination, all this will be tailored and adjusted to you and whatever your general health is like. So treatment is always individualized, it's not a standard treatment. Autologous stem cell transplant, as I mentioned, I'm not going to cover. I think I'm running out of time. So for fitness for the transplant, we need to be assessed. Yes, discuss this with your treating hematologist. I'm happy to answer any questions, and if there are any questions, happy for the Myeloma Australia to forward them to me. But for a general slide here is just what is available on PBS for relapsed myeloma, and this changes all the time. Again, like I said, many changes for the past 10 years. We have so much more available now that we didn't used to. My slide clicker is not working. Yeah, thank you. Hold on. So what are the treatments in relapsed myeloma available? We have clinical trials now. We have a lot of new therapies. You've heard a lot about CAR T therapy. At the moment, that's available on clinical trials in only some centers. There are antibodies and very different things now. And I think the future of myeloma, the overall survival of people with myeloma is looking very, very promising. So supportive care, I'm going to take 2 minutes because I think this is very important. So what is important in myeloma, apart from the treatment, we need to make sure, and I always like to talk, we need to make sure that we can try and aim for good quality of life. If there's pain, bone pain relief is essential. Radiotherapy may be useful for pain relief. If someone's got a lot of bone involvement, radiotherapy you can get a quicker response just from a little bit of radiotherapy, and also that can help with some pain relief at the site. Surgery if appropriate. If bone protection, another topic that's close to my heart. Now, what we need to do in myeloma is, even in people who haven't had any bone lesions, there are in the bone microenvironment a lot of myeloma affected activity going on. There's increased bone destruction. So we need to look at how we're going to prevent further bone damage. So bisphosphonates, you may have heard of this, Zometa, palmitoic acid, that's important to try and slow down the bone turnover. It's like to slow down the destruction of the bone. And that's something that should be considered in everyone with myeloma, even if they didn't have any scan evidence of bone disease. The problem, I'll do that next page. But also the other issue with myeloma is there's a risk of infection just because you had myeloma already. Remember, the bone marrow, plasma cells secrete antibodies, but the normal antibodies from the normal plasma cells, that part can be a little bit subdued and suppressed because the bone marrow is producing a lot of abnormal myeloma cells. So some patients are at risk of infection, vaccination. Be careful going out. We have COVID now. That has been quite a difficult situation for all of us. I would say just keep safe, keep up with your vaccinations, discuss it with your treating hematologist. There are also treatment-related risks, so infections, high sugars from steroids, gastritis if you are high dose steroids, that's right. It can cause some gastric erosion, so make sure that you've got some adequate protection for that. And of course, one important thing, clotting risk. Some of our myeloma medications and having myeloma itself can sometimes not sometimes, but it does lead to an increased risk of clots. So, make sure that we think about that and there's some adequate plan in place to prevent this. Always make sure before we start bisphosphonates, Zometa or palmitoic acid, always make sure that you keep up with your dentist's regular dental review. There is a rare condition called osteonecrosis of the jaw, where there's an infection in the jawbone here, exposed bone, that is really very difficult to treat. And because bone is not a soft tissue that heals, that makes it, once you have ONJ, and if it's a severe one, there can be ongoing problems with that. One of the ways of preventing this is to have a good dental review. If we can, before treating with bisphosphonates. If not, because if there's an emergency, then a dental review after the first dose, if we can. Dental health would be the mainstay of prevention of all osteonecrosis of the jaw. So a few resources, and I found this to be quite useful for the local resources. There's Myeloma Australia, the Leukemia Foundation, and the Cancer Council website. There are a few overseas resources, but I think these would be the main ones that we should refer to because they're quite good. Thank you.
Thank you so much, Angie, for that very in-depth overview. We really appreciate your time. We do have a couple of questions. The first one from Jonine. How high can your paraprotein levels go before it causes damage?
It doesn't need to go high before it causes damage. Remember that slide I showed with the plasma cells and the antigens being secreted. Sometimes you can even just have a low paraprotein of 8 or 10, and you have a lot of features of myeloma, bone features or kidney features. Remember, there was a slide that I said about non-secretory myeloma, where sometimes the plasma cells don't secrete the paraprotein. So, and yet people still get the full crab feature. So you actually don't, the number doesn't tell you that you're safe or not safe from for having features of myeloma. It's more related to the scans, what the numbers are doing, and exactly what's happening. It's hard. It's not a one-size-fits-all kind of thing, and that makes myeloma just a little bit more tricky to explain because everyone's a little bit different.
Yeah. And we have time for one last question. I have smoldering myeloma. is there anything I can do to prevent it from transforming into multiple myeloma?
I get that question a fair bit. The short answer is no. There is unfortunately not much to do to prevent transformation to myeloma. But what I always say can be done would be keep healthy, keep fit, make sure that the dental review is fine. Because when the time comes for treatment, and we don't know when that will happen, but when the time comes for treatment, you are as prepared and as fit as possible to have the best outcome from treatment.
Thank you so much again, Angie, for your time today.